Our first case is a 71-year-old man with hypertension, hyperlipidemia, diabetes, HIV, obesity, and sleep apnea, who had a PCI for a chronic total occlusion of the mid-LAD 2 years prior. This relieved his symptoms at the time, but he returns now with chest pressure that's mid-sternal with exertion, which improves with rest and sublingual nitroglycerin. This has been increasing in frequency and associated with shortness of breath. It lasts for 5 to 10 minutes at a time, and at the same time he's also asking us to clear him for his colonoscopy. So if you look at these views here on the LAO cranial, you see what looks like diffuse disease of his proximal LAD, proximal to the stent. The stent itself looks reasonably patent. On this RAO caudal view, the proximal portion of the LAD seems a little more obscured by the ramus artery. The ramus artery also has a bifurcation lesion in its distal segment. So, is there really an LAD lesion or not? We know that the LAD is often foreshortened in the LAO cranial, so it's also obscured by branches in the RAO cranial and in the RAO caudal. So what do? Well, of course you measure physiology, and sure enough, the iFR is 0.79. But more importantly, the iFR co-registration tells you exactly where this lesion is ischemic. It's not ischemic in the stent itself, which looks good, but more importantly, it doesn't have any of these dots that reflects the step-ups in the iFR pullback. So in this measurement here, most of the dots come at the proximal LAD well before the stent. This is overlapped with the ramus artery in this view. However, you can be assured that if we fix this lesion proximal to the stent, that you could have a potential increase in the iFR of approximately almost 15, 0.15, and that would be a highly effective stent to place. So using IVUS at the same time, following placement of the stent in the proximal LAD, we're able to demonstrate that with IVUS co-registration, the stent is well opposed and well expanded, and that there's no residual lesion proximally. So what about the ramus? We see that there's a bifurcation lesion there, and it looks tight, but it's a relatively small branch, and it's at a bifurcation. Which vessel do I fix? Which one is the main branch? Well, with co-registration, you can actually determine by placing the wire in the upper branch of this ramus that the iFR in the distal upper branch is 0.90. This would be non-ischemic. But most of the step up there is right at the ostium of this upper branch. If you go in the lower branch or equally sized lower branch of the ramus, you see that the iFR there is actually 0.84. So even though these vessels seem fairly equally sized, I now know that I can preferentially place the stent in the lower branch to cover up the upper branch because I know that one's more ischemic. So fortunately as well, the iFR co-registration has demonstrated that it's a very focal lesion. All of the ischemia is being derived solely from that one spot at the bifurcation. Now, you can place a stent across the upper branch and and hope that it doesn't have any plaque shift. But what we did was something else. We actually placed the pressure wire back into the upper branch, fixed the lower branch, and then kept the measurement afterwards. So here's the other benefit of the co-registration is that it comes with QCA, somewhat automated, which allows you to measure the diameter stenosis, in this case of the upper branch, of 50%. So it actually gives you high magnification views of this bifurcation, which is very, very helpful. We decided to pre-dill the upper side branch on its own in preparation for bifurcation lesion. And we measured a post-PCI iFR in the side branch, the upper branch, with no significant step up into the main branch. So in other words, we successfully stented the lower branch without having to have any impairment on the upper branch. And this IVUS helps demonstrate that the stent is well opposed and post-PCI iFR was relatively normal. So this is an example where iFR co-registration definitely helped us both select the artery and the artery branch in which we wanted to fix, and also ensure that it's just a focal lesion and not something else that we needed to fix.